Hi, I'm Jodi Lyons. Welcome to Your Need to Know. I'll be your host today, and I am thrilled to once again have our guest, Dr. Sassan Hassassian, and he is an affiliated physician with National Spine and Pain located in the Manassas, Virginia office. So welcome back. I'm so glad you're here.
Thank you.
Today we're going to talk about some pretty detailed information about pain and what kind of procedures you do. Earlier we had talked about what an office visit is like, and we had addressed a myth, which was you're not basically cutting open everybody's spine and filleting them.
Correct.
But what I really wanted to get into today was exactly what it is you do, what kind of procedures, what they take, how long they take, what patients can expect. So can we start with like the simplest? So somebody's come in and they've gone through your assessment with you. What's the first thing you try?
So again, goes back to where the source of pain is. Obviously, that determines the type of procedures, but very broadly speaking, the types of procedures we offer can vary from the least invasive, which would be very simple injections in the muscle, to taking it further to do procedures around the joints and ligaments around the spine, versus actually what we call intraspinal procedures, the procedures that happen in the spinal canal itself. And these could be in the form of injections, of steroid, or sometimes what we call regenerative interventional procedures, such as PRP injections. We can talk about that later.
Okay.
We can do ablations, basically burning the tip of the nerve endings if there is an issue there. For more involved stuff, we can do implants, nerve stimulator implants, and there are even minimally invasive procedures can be done in the spine itself. But for vast majority of the patients, these procedures are pretty much all within 15-20 minutes. Most patients do not require a driver. They just wait in the office for 20 minutes and they can leave. Obviously, they all get numbing medication.
Right, right.
So some patients who are more anxious than others, we have other ways to handle that as well. We have the ability to provide nitrous gas, or they can come if they have a driver for that scenario, to give them something to make them more relaxed to have the procedure.
So you're not causing pain to get the pain procedure.
That would be the ideal goal.
Okay, that's
correct.
terrific. And
Yes.
and you can deal with anxiety, and you're used to dealing with patients who are afraid. So that's nothing
Correct.
unusual for you.
Absolutely. A lot of times patients say, how come I'm not going to sleep? And actually, I prefer not the patient be completely out of it, because that is a form of monitoring for me, because what patient tells me is the best neurologic feedback as to what's going on, as opposed to a patient who is basically unconscious and cannot provide any feedback. So again, these procedures could be, say, epidural steroid injections to decrease inflammation on the back end of a disc that might be putting pressure on a nerve root, causing what we call radicular pain. Patients call it sciatica. Or we could do some procedures on the arthritis part in the back of the spine. The joints are called facet joints. And again, I think we talked about it before. A lot of times, especially in the older population, the question, again, is not this or that, is how much this, how much that, because there are multiple issues going on. Yeah, if somebody's 10 years old, probably it's just one thing going on. But once you're past age 30, 40, 50, and then as you get up there, then a lot of things are in that equation. So we just have to determine which area requires attention first, and then move on to the other things.
So you just raised a really interesting point. I think what I hear is my back hurts, and I think people think it's one thing, my back hurts, and they can point to their back. And what you're saying is, let's just say we're talking lower back pain, and the stereotypical person leaning forward, hunched over because it hurts too much to stand up.
Correct.
What you're saying is there might be multiple reasons for that?
More often than not, in older population, there is more than one variable. So the role of the pain specialist is to figure out which area causes the problem first. And then you kind of attack that area. Obviously, you want to focus on less invasive measures and kind of go from there. But it's very possible for someone who have arthritis in the joints and at the same time have degenerative changes in the disc between the vertebra, or as you mentioned, the hunched over patient, that's usually indication of narrowing in the spinal canal. We call that a stenosis, which can cause nerve-related back pain, whereas arthritis can cause what we call mechanical back pain. So just because I treat the arthritis part does not mean all of a sudden the stenosis goes away. So there are different tools for different parts.
And you go sequentially, basically, because
Correct.
you have to deal with multiple pieces.
Correct, and exactly.
So somebody who's getting an injection in their spine shouldn't necessarily assume that miraculously everything's going to be better, because that might be one of 3 things that you need to treat.
Absolutely.
That is really
it's like
interesting.
going a place, there are 3 sets of fire going off. Just because you put out one doesn't mean the other 2 just went away. So we
That's
have to focus
fascinating.
accordingly.
So can you tell me a little bit, let's start with, what is the simplest thing? And I know that's kind of a loaded question, because your answer is going to be simplest thing for what disease, but let's start with whatever you think is the easiest.
Simplest of all things on a scale of 0 to 10 being less than a 1 is what we call a trigger point injection. Basically, they have isolated area of muscle that is in spasm and causes localized pain. So we can put some medication, local anesthetic and whatnot in the muscle to relax it. And then you move on to the other things. And as I said, you know, it depends on the situation. A lot of times we see patients who have a herniated disc and have sciatic or radicular pain. So now we talk about epidural steroid injections. And then there are situations where we don't want to do steroid, or you have done steroid. Depending on the situation, then we can talk about one of the areas that I focus on is called PRP injection. PRP stands for platelet-rich plasma. Platelet is basically these elements that in the blood, they cause coagulation. Everybody has them. But we know that if we concentrate platelets and purify it and inject that instead of steroid into the affected areas, then you use your own body's anti-inflammatory mechanism to decrease inflammation.
That is amazing. So let me just repeat that, make sure I'm understanding. You're basically taking somebody's own platelets.
Blood, yes.
Okay, and so blood.
Correct.
And then you're spinning it or enhancing it or something else to make it platelet-rich plasma.
Correct.
And then you're injecting that back into their own body?
Correct, into the joint, around the spine, around the ligament that might have a tear, because with the platelets, not only you can decrease the inflammation, but they also have this ability to recruit growth factors. So in essence, there might be some elements of regeneration of a tissue that's been problematic. Whereas if you do just plain steroid, you're just decreasing inflammation, there might be no regenerative process. So that is one of the...
So when would you use PRP?
When?
Yeah. What kind of an example
No,
would that be?
you can do it for arthritic knees. You can do it for people who have cartilage tear. You know, they have ligament tear, tendon tear. So, you know, arthritis in the spine itself. It can, you know, any place that you can put a steroid, you can pretty much put PRP minus the side effects of any steroid that might
That's
exist.
amazing, because we all know sometimes the steroids have some unwanted side effects.
And you can only give so much of a
Right.
steroid because, like I said, it can have, I mean, obviously we dose it correctly and we keep track, but obviously if you don't do it correctly, then they have bone density problems and cartilage problems, but that is not an issue with PRP injection.
That's amazing. And so you would use that for not spinal stenosis necessarily, but some of the other
a whole
things.
host of other things that can be done. Correct. You can use it in hands, shoulders, knees, hips, spine, all of it.
And how long would that procedure take?
These are a series. I tell patients with PRP think about it like putting a seed in the ground. The tree does not go up the next day.
Right.
So this is a process. So when you measure the effect of a steroid over days to come on board, the PRP, the results are seen within months, but they also last a lot longer. So the PRP is a long-term strategy as opposed to short-term relief.
That's amazing. So that sounds like something that is actually, quite honestly, takes less time than a good pedicure does. So that's very interesting. Now, I'm sorry, you were about to say something?
No, I mean, like I said, as far as other procedures, I mean, again, now let's talk about situations where pain has been there for a long time. Patient has surgery or multiple surgeries in the back. There's scar tissue around the nerve roots and things of that nature. So we don't want to do more surgery because that creates more scar tissue. You know, these are the cases where what we call neuromodulation or spinal cord stimulation come to place. I tell patients, think of it like a pacemaker. You have a pacemaker for the
Okay.
heart, it's like a pacemaker for the spine. But the idea is not to go through major surgery, not to disturb the surgical part. And it entails placement of 2 small wires in the back of the spine, and they act as pain suppressors. One of the other indications that recently FDA basically gave over the past few years is painful diabetic neuropathy. So people who have diabetic neuropathy in their feet and they have not responded to other measures,
Right.
this type of neuromodulation procedure now has an indication for it.
So you say you're putting the wires in, and I'm sorry to put you on the spot and have
Sure.
you describe this in 2 minutes.
Sure.
I feel like it's one of those cliff notes.
Yes.
So the wires go into your back, and what are they connected to?
They get attached to eventually to a battery that is also like a pacemaker, but for the pacemaker goes in the chest, this goes in the back of on the skin, underneath the skin in the buttock.
Okay.
But before even doing that, this is one of those procedures patients essentially get to test drive the car before the buy-in.
Oh, okay.
So we do what is called a trial, where we put temporary wires in the back, and they go home with a wireless device that is basically taped to the body, and
Okay.
they test drive it for 5 days. And it's not what I say or what the neighbor says, it's what they say. So if they
That's
don't
always
like
the
it,
biggest- yep.
it's not for them. If it really improves the pain and again functional status, then the next go round everything goes underneath and nothing's on the outside anymore. And the battery lasts about 7 years.
And how big is this battery?
The battery is like a pacemaker battery, maybe smaller. It's about a silver dollar, if you will, about
that's
this big
amazing.
and about this thickness.
That is absolutely amazing. I mean, the technology's clearly improved that we're now able to put something in the size of a silver dollar into your back and have the pain go away.
This has been around for decades at least, but imagine what your cell phone could do 15 years ago.
We used
what
to
it can
have the
do
bricks.
now.
Absolutely,
Yes.
absolutely. Well, we're about to head into a break, and when we come back, I hope we'll talk about some other procedures.
Right.
Now that we've gone through some very easy, and I'm using air quotes here. Everybody, thank you for watching Your Need to Know, and we will be back in just a few moments.
Opiates has taken everything and everyone I've ever loved away from me. Everything.
I blew my ankle out and I got prescribed pain pills by my doctor.
If making my detox public is gonna help somebody, I'm all for it. I just wish I would have had a warning.
Opioid dependence can happen after just 5 days. Know the truth, spread the truth.
Mom! I got it. What are you doing in there?
I got stuck.
Are you a dog?
I wouldn't do that. Have you seen the pliers? Where'd you find those?
It's not your birthday.
Sorry.
Bye, Grandpa.
Bye, Grandpa.
Take care of yourself.
What are you doing? What are you looking for?
If you smoked, this new lung cancer screening could save your life. Visit SaveByTheScan.org.
Caitlin, be serious. No, take the oath. Come on. I'm totally taking this seriously. Okay, I'm ready. You may begin. I pledge that I will never meet in person with anyone I first met online without checking with my parent or guardian. And furthermore, if my parent or guardian agrees to the meeting, it will be in a public place and my parent or guardian must come along. Do you pinky swear? I do.
When you teach your kids about internet safety, they'll pass it on. For more information, go to cableclicksmart.org.
Hi, Hi, and welcome back to Your Need to Know. Before we left for the break, we were talking about some minimally invasive procedures for pain. And I was being flabbergasted that the battery for the stimulator
Yes.
was basically the size of a silver dollar. So what other kinds of procedures are you talking about? Again, I think I had the same misperception everybody else did.
Sure.
That these are big, hard things to do and they take a long time. And you're saying you can do it in your office. I'm not meaning to minimize it, but...
Right. Let's pick an example that is very common.
Okay.
And also has a very good efficacy record, if you will. So, and that's having arthritis in the joints in the back of the spine. Okay. So this can happen in the neck, can happen in the back. Also, you can see it in people who do not have arthritis, but they were involved in a what we call whiplash type of scenario.
Okay,
in a
like car accident kind of things.
Accident,
okay.
But everybody has some neck pain, but then this is the kind that lingers.
Okay.
So behind each vertebra, we have two joints that kind of gives you some rotational motion. They're called facets, F-A-C-E-T, and they are prone to become problematic as we go through life. Okay. And it's very common to get arthritis in these joints. So that's one of those areas that we say, where is the pain it's coming from? Is it this or is it that? And then it becomes how much this, how much that.
Because it could be both.
Because these people not only have arthritis, but they might have other stuff going on, stenosis or disc issues and whatnot. So one might say, okay, let's get imaging studies. Okay, we do, but imaging study can only give us so much. And a lot of times I tell patients, just because something looks goofy on an image does not mean it's painful.
Okay.
And not every degenerative process is a painful process. People laugh, but I say, do you have wrinkles on your forehead? They say, yes. I said, is it a degenerative process of the skin? Yes. Does your forehead hurts every day? No. So
okay, that's a very great parallel.
Exactly. So just because it's degenerative doesn't mean it's painful. But that at least gives us a clue as to what's going on when you get an MRI. So now we have to determine. So let's say how we work up the facet joint. So by looking at it, you cannot tell. It's the same way that you can look at two switches on a wall and decide which switch controls the light. You can look at it, you can take an MRI of it, it would not help you. You have to flip one switch, see which light goes off. So that's how I tell the patient. So I think that some of these joints are causing the problem. So we say we're going to do a test, but it's an injection test with numbing medicine only, no steroid. It's not a treatment.
Oh, okay.
So basically come under x-ray, we pick the joints that we think are problematic. We think, we're not sure. And we put a little bit of numbing medicine around these joints and temporarily numb them up for a few hours. Once we put that in, patient leaves, they go about their typical activities. They are supposed to do activities that are painful, and it's numbing, it wears off. Then they call me back a few hours later and give me a report. So if the joints or the arthritis part is really the primary problem, then they should be pretty happy. We flipped the switch, light went off. The message is, Dr. Hassassian, that was wonderful.
Now we know where the problem is, okay?
If the joints are not the cause, then numbing them makes no difference. So let's say they had a wonderful experience, short term. Now what do we do for treatment? So unfortunately, we don't have a tool to cure arthritis.
Okay.
That would be later, probably through genetics and regenerative stuff. But for right now, we can alleviate the pain though. And it's not a surgical issue. But what we can do is called radiofrequency ablation. So radiofrequency probes, they look like needles.
Okay.
And we basically introduce that probe to the area where the tiny nerves that go to the joint and use radiofrequency waves to ablate or burn the tip of the nerve endings. So now instead of just a few hours, you can knock it out for about 6 to 10 months before the nerves grow back. Now, if it's a younger person, doesn't have a lot of arthritis, whiplash, it's a procedure you do one time and you're done. If somebody has a lot of arthritis, obviously, you can repeat it if you need to. If you don't need to, don't worry about it. No incision made. And again, the idea is decrease the pain, also improve functional status.
That is amazing. And again, done in your office.
In the office, and these are all 15-minute, 20-minute procedures.
Wow.
Yeah.
And so what else would you say is a next step? So let's say they had spinal stenosis.
So a spinal stenosis depends on, is it a canal, basically central canal, or is it on the holes where the nerves go through? So,
Okay.
because then we call foraminal stenosis, that's the fancy name for it. So again, early on, you can do steroid injections to decrease any inflammation. A lot of times with the stenosis, the problem is not necessarily inflammation, but it's the pressure causing the blood flow to that area of the spine to be compromised a bit around the nerve roots.
Okay.
So there are some more advanced procedures that become somewhat surgical in nature, that we can put spacers between the interspinous processes, between the two vertebrae, to kind of distract them and create more take the pressure off of it. But early on, again, you can do steroid injections, you can do PRP injections. A lot of times PRP people think of it as the anti-inflammatory, but in older population, it's not just the disc that is compressed. Think of it, the scaffolding around the spine, all these ligaments. And these ligaments, over time, they kind of get buckled. So they don't really provide support for the spine.
Oh,
so if somehow you can, not necessarily rejuvenate, but strengthen these ligaments, you can take the pressure off the spine part. So that's where the PRP comes in, or regenerative interventional procedures. So we basically target all these ligaments. So over time, these ligaments become basically more rejuvenated, if you will. And by doing that, indirectly, you're taking the pressure off the spine in the middle.
So you could basically do a combination of injections, steroids or not,
Correct.
PRP, the ablation,
Correct.
and the sensors
Correct.
for neuromodulation.
Yes, that is correct.
None of which involves surgery.
Correct. And the stimulator at the end requires it's a 45-minute surgery to implant it, but for the trialing it all the other stuff, they don't require any incision.
That is absolutely amazing.
Yeah.
If we could switch gears a little bit, because I have been fascinated about the procedures, I think we need to talk a little bit about something you alluded to earlier, which is medication management and pain management through medications. Right. I know the first thing that people worry about is becoming an opioid addict.
Correct.
Can you address medication and how you can treat with medication responsibly?
Absolutely. I mean, opioid crisis is a real crisis. No question about it. So, and it's a multifaceted problem. Okay. So we have to look at it from societal, social issues, economic pressures, and everything else. But at the end of the day, from my end, obviously, like I said, patients come to us not to be dependent as much on medication or not to take medicine. But there are situations where medicine is appropriate.
Okay.
Say somebody has rheumatoid arthritis or they have cancer. So it's not like we can operate and do an injection in every joint in the body. So medicine is appropriate. So it's proper use of this as a tool in the toolbox, not the only tool that you pick up and go with it. But at the same time, you have to be aware, and the patient needs to be very aware of what at stake is when we go through these medications. So a lot of times, I'm going to go over one concept very quickly. It's called physical dependence versus addiction.
That is a very good
because
point.
Physical dependence, a lot of people, even a lot of physicians kind of get that confused. Physical dependence means that if you take a medicine long enough and you stop it, you will get the opposite effect of that medicine. You can be physically dependent on your blood pressure medicine. It does not mean you're addicted to it. Okay. In other words, if you pick something that decreases your heart rate as a blood pressure, like a beta blocker, but if you stop it immediately, then your heart rate races, it goes up. Are you addicted to your blood pressure medicine? No, but you're physically dependent on it.
Okay.
Okay? And so that, people get that confused. If you're on opioid or some other medication, then if you stop it, you're gonna have more problems, but that's a physiologic reaction. That's not addiction. Addiction is purely a psychological issue. And there are different ways of defining it. People say people hoard medications. They do it because they want to get high, whatnot. But a long time ago, when I was in training, a psychiatrist told me something that kind of stuck with me, and I always use it. And basically, two words define addiction. Only 2 words. And you can apply to anything: medication, gambling, alcohol, anything. And those 2 words are despite harm. If you do any activity despite harm, you're aware that it's harming you. Now, harm could be physical, could be family, could be money, could be economic. If you do it despite harm, then it's an addictive process. You're addicted.
That is amazing. Okay, and I'm going to keep that now. I'm going to have this. Your professor is going to be training a whole new generation, right? Despite harm.
Correct.
So people who are dependent on whatever kind of medication it is. They could be physically dependent and or psychologically dependent. And the trigger would really be despite harm.
Despite harm, correct.
So there are people who could be physically dependent on a medication that's not necessarily bad because it is keeping their blood pressure under control or helping them function. Is that correct?
That's 100% correct.
Okay.
All anti-seizure medications, patients
That's
are
a very
physically
good point.
dependent.
Okay.
Yes.
Physically dependent, so they don't have seizures.
Correct, but if they stop it, they're going to have seizure.
Okay.
Very quickly.
So we have about a minute left.
Correct.
Do you have any words of advice about opioids or other pain meds or anything you want to make sure that our audience knows?
I think this is where the pain specialists come in because we got trained for it. Now, some people might do more procedures like me, some people might do less, but at the end of the day, I think if there is a need to go that direction, either even a small amount or a short-term basis, it's better to have a pain specialist on board early on because then we look for those red flags that might not be as apparent to other people or to other providers or clinicians. So we would like to be part of that conversation early on because those are some of the things that we don't want initiated for no reason because there's a cost for that as well. So it has to be appropriate.
That's a very good point, which also is that the doctors all need to talk to each other. And I think sometimes the patients don't recognize that the doctors aren't talking to each other, so it needs to be a team approach.
A team approach is the way it is.
Okay, that makes perfect sense.
Correct.
And what I'm hearing is the other takeaways are, number one, don't be afraid. If you're in pain, deal with it and go to a pain specialist.
Correct.
And work with that specialist to come up with the plan that works for you and to stay away from doctor internet and medical advice from friends and neighbors who are different.
Like, that would be the best
this
advice.
This is all very individualized.
Absolutely, it's not cookbook, everybody's different.
Okay, that is a great takeaway message.
Yeah.
And with that, I'm going to say thank you so very much for watching Your Need to Know. And we can find you at treatingpain.com in the Manassas office. Once again, thank you so much for joining me, and thank you for joining us on Your Need to Know.